Hi, everybody, and welcome. We'll just give everybody a few minutes to come into the room before we start. So participants continue to trickle in, so we'll give it another 10, 15 seconds or so. Okay, I'll start. Hello, and welcome to the question and answer session on aggressive B-cell lymphomas. My name is Antonella, and I am the CEO at Lymphoma Canada. It's my pleasure to have you join the Q&A period today. I'm pleased to welcome today Dr. Robert Puckrin to answer your questions from the breakout session on large B-cell lymphoma and other high-grade B-cell lymphomas. For those of you that did not attend the large B-cell lymphoma breakout, Dr. Puckrin is a hematologist and staff physician in the Alberta Blood and Marrow Transplant Program at the University of Calgary. As a reminder to our audience members, please type your questions into the Q&A box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. So let's get started. We already have a few of them that are coming through, which is wonderful. The first one I have is, what characteristics makes large B-cell lymphoma aggressive? What does that actually mean?
That's a great question. So it has a lot to do with the biology and the genetics of the tumor. So when it comes to lymphoma, there really is a spectrum of ways in which these cancers can behave. Some are what we call indolent, meaning they're very slow growing and they can develop over a period of many, many years. They may not require treatment for a long time until they start to grow large enough that they're causing problems. On the other end, we have the more aggressive lymphomas, of which diffuse large B-cell lymphoma is the more common one. That just means it tends to grow more quickly. So it tends to develop over a period of weeks or perhaps a few months rather than years. And because it does grow quickly, it can also be quite dangerous and even lethal if it's not treated properly. The good news is, with effective treatment like R-CHOP chemotherapy, these aggressive cancers often can be cured.
Okay, great, wonderful. I am hearing about more targeted or precision therapies being developed. Will there be a day when these might replace chemotherapy and be used in earlier forms of treatment? I had a really hard time with chemotherapy, says this patient.
Yeah, so I think we're already getting to that point where we are seeing new immune therapies and targeted therapies being used for the treatment of this lymphoma. So with CHOP, we've already added on an immune therapy, rituximab, which is an antibody that's really targeted to the lymphoma. We've been doing that for at least the last 20, 25 years. Now for cases which have relapsed, we have access to new targeted and immune treatments like CAR T-cell therapy. Soon, I hope we'll have bispecific antibodies and other new treatments as well that are given almost entirely without chemotherapy. And there are lots of clinical trials ongoing looking at these newer treatments as part of the first or second treatment for diffuse large B-cell lymphoma. So I think the day is coming very soon in the near future where we will be shifting towards these new treatments and relying less on chemotherapy.
Okay, wonderful, thank you. I have a question. It says, I guess this audience member has received treatment for relapsed refractory double hit lymphoma after EPOCH-R chemo treatment. Is it best to have CAR T cell treatment as the next treatment option?
So double hit lymphoma, it's a bit of a tricky subtype of diffuse large B-cell lymphoma. We find it in about 5 to 10% of cases, and it means that these particular tumors have a couple of genetic changes involving two particular genes. One is called the MYC gene, MYC, the other one is called the BCL2 gene. And when these two genes are affected, it can make the lymphoma a bit more difficult to treat, and it tends to have lower cure rates with typical chemotherapy compared to regular diffuse large B-cell lymphoma. So because of that, we try to use stronger chemotherapy like EPOCH-R, which was mentioned here. That may vary a little bit between hospital to hospital and province to province. Cases that don't respond well to chemotherapy, in the past we did try to use stem cell transplants, but we found that isn't successful in as many cases just because the lymphoma tends to be more resistant to chemotherapy. So this is really the group of patients where we really try to get them to new types of immune and targeted therapies. So that's where CAR T cell therapy really is probably the way to go for these patients. Right now, we only have access to CAR T cell therapy in third line, which means that a patient has to receive R-CHOP first. If that doesn't work, then we give a different type of chemotherapy and sometimes a stem cell transplant second. And then we have the option of CAR T cell after that if we need it. But there have been some recent trials showing that using CAR T cell therapy as the second treatment instead of some stem cell transplant tends to be much more effective, especially for these higher risk cases. So hopefully within the next year or so, we'll have access to CAR T cell therapy as the second treatment for those patients who need it, particularly those with double hit lymphoma.
Okay, that's great. And it's actually a wonderful segue. We received, I think, 1, 2, 3 questions on a CAR T, so maybe I'll try to combine them. It says, when will CAR T therapy be available in Western Canada? Other questions included, if CAR T is not available in my province, does that mean I am ineligible?
Those are great questions. This is a very new treatment. It's only been around in the US for the past 5 or 6 years, and in Canada, it's only really taken off over the last 2 to 3 years. Back when CAR T cell therapy first became available in Canada, it was only offered at a couple of centers in Quebec and Ontario. But now, fortunately, that is expanding across the country, and most provinces now have a CAR T cell therapy program or are soon to have one. So I know in Western Canada, here in Calgary, as well as Edmonton, we have active CAR T cell therapy programs. I know Saskatchewan is up and running. I think Manitoba is soon on the way. And I hear that British Columbia is also soon going to have their own CAR T cell therapy program. So there still will be access issues because it is a very specialized treatment, and it typically has to be given in a very specialized center. And there may only be 1 or 2 of those in provinces. And that's a challenge in a very big country like ours, where many patients do live hundreds or even thousands of kilometers away from a treatment center. But now with these new programs opening up, I hope that access will become easier.
That's great. And I think, so would a patient that, let's say in BC right now, is not able to access that therapy, be able to gain access to that therapy in another province?
Yeah, so there usually are ways for that to happen. I know some patients in BC have been able to travel to Ontario to receive CAR T cell treatment. In Alberta, before we had our own program open a couple of years ago, we actually had patients travel to the United States to receive their CAR T cell treatment. It can be a bigger ordeal. It's a lot to go through as you're going through cancer treatment to make that trip. But if you discuss with your oncologist and see what options are available, often something can be sorted out.
Okay, wonderful. Another question I have here, it says, I'm a patient in BC and I joined a national support group where I met another patient from Quebec with the same subtype. My treatment when I relapsed from my initial diffuse large B cell diagnosis is different from the person I met from Quebec. Why would that be?
Yeah, so every person with this lymphoma is different, and the treatment plan for each particular patient may depend on a number of factors. So, in general, if this lymphoma relapses, there are certain principles that we follow. We give a different kind of chemotherapy. We often use a stem cell transplant or CAR T cell therapy, but that treatment plan can be individualized depending on the hospital, province, and the individual patient. So depending on your age, on how many other health conditions you might have, on how aggressive the disease might be. Those are all factors that can influence your doctor to help pick the next chemotherapy that would be most appropriate for you.
And will the availability of a particular therapy also impact that within a province?
So the availabilities of therapies does vary a bit from province to province. Quebec, they have their own system where they review new medications and decide on whether or not they're going to be funded and approved. So that can be a bit different. There are some drugs that are available and approved in Quebec that aren't approved elsewhere in Canada. The rest of the country, we tend to use the same organization, which is called CADTH, and they review all these new medications and decide which ones will or will not be funded in the rest of the country.
Okay, wonderful. Thank you. I have my next question. It says, when does it make sense to have central nervous system scans or tests? As I've heard that diffuse large B cell can be in the brain.
Yeah, so in about 5 to 10% of cases, diffuse large B-cell lymphoma can affect the brain. It usually tends to occur in those who have risk factors, and usually they have to have multiple risk factors. For example, lots of different areas of lymphoma, or very high LDH, which is a blood test marker. It can occur at the time of diagnosis, but more commonly it occurs during the first 6 to 12 months of treatment. So certainly if a patient has signs that the lymphoma may be affecting the brain, then we will do some imaging like an MRI scan of the brain. Those signs can be various, but often it includes things like headaches or drowsiness, confusion, personality changes, weakness. So certainly if any of those signs are present, then a scan will be done to make sure there isn't any signs of lymphoma in the brain. You know, the question comes up, should we be doing screening scans at diagnosis? That varies a lot from doctor to doctor and hospital to hospital. There really is no standard because it is still fairly rare for lymphoma to be affecting the brain at diagnosis, especially in someone who's feeling very well if they have no symptoms.
Okay, great. Our next question is, if we had a diagnosis of follicular cancer, but it transformed to diffuse large B cell after R-CHOP treatment, will that kill both cancers, or will the follicular still be there?
So in about 10% of cases of follicular lymphoma, the disease can eventually transform to this more aggressive disease. We tend to treat the more aggressive disease, the diffuse large B-cell lymphoma, because that's the one that's most life-threatening. The good news is the R-CHOP chemo does work very well for both of the cancers. In fact, if a person's never had treatment for their follicular lymphoma, then they'll probably do just as well as any other patient with diffuse large B-cell lymphoma. If they've already had chemotherapy for follicular lymphoma and now they've developed the more aggressive cancer, that can be a trickier situation where the R-CHOP itself may not work as well. And we often use other treatments like a stem cell transplant, or we may look at other new immune treatments like CAR T-cell therapy in some cases. But in general, we can treat both cancers with R-CHOP. The diffuse large B-cell lymphoma tends to have a higher cure rate, meaning around 60 or 70% of cases will be cured by the R-CHOP. The lymphoma never comes back again. The follicular lymphoma, it behaves a bit differently. It tends to be less curable, but it still is treatable. So it will probably go into remission on average for many, many years, but it does have a higher tendency to come back, sometimes years down the road. The good news is if the follicular lymphoma does come back, we still do have other treatments available for it and lots of new immune therapies coming down the pipeline for it as well.
Okay, wonderful. The next question is, how do you determine whether to suggest a CAR T or another therapy like a bispecific treatment for your patients? Are there certain characteristics that determine best treatment to go with?
So CAR T-cell therapy and bispecific antibodies, they've never been directly compared in a clinical trial, so we don't truly know which is better. But from what we do know, they both seem to work probably reasonably well. The CAR T-cell therapy, it tends to be or have a higher risk of side effects compared to the bispecific antibody. And the CAR T-cell therapy also tends to take longer to manufacture. It takes about a month to actually produce it, whereas the bispecific antibody is usually available right off the shelf. Right now, CAR T-cell therapy is the only one of the two that's funded and approved and available in Canada. Bispecific antibodies, we right now have access to them through clinical trials, but they're not yet routinely available in regular use. But hopefully within the next year or two, we will have access to both. So the decision between the two will depend a lot on each situation. If a person is able to receive CAR T-cell therapy, we probably would go with that first, just because it's been better studied. We've got a lot of clinical trials, and we have long studies showing that it can cure a significant proportion of people who have lymphoma. Bispecific antibodies, we don't yet have as much information about how well they work, but the early results do look very promising. But they still can be a very good option for people who may not be eligible for CAR T-cell therapy because of maybe other health conditions, or if they live too far away or unable to travel to a CAR T-cell center, or if their disease recurs despite CAR T-cell therapy, then the bispecific antibody would probably be the way to go.
Okay, great. I'll go to the next question. It says, I have a rare condition, diffuse large B-cell double hit lymphoma. I have received 6 cycles of chemo and 45 radiation treatments and have survived despite the projections given to me. I'm wondering, where can I learn about medical studies or clinical trials that I can fit into? My goal is that perhaps my case might help other people in future.
Yeah, that's a wonderful thought. And it sounds like you're doing very well after your treatment, and which is fantastic news. We do find that even if you have double hit lymphoma, if you do respond well to chemo, then you still tend to do quite well over the long term. So that's my hope for you as well. You can certainly chat about the possibility of clinical trials and other new treatments with your oncologist. That may vary a lot from hospital to province, but most of us are in the loop as to what clinical trials are going on around the country. And can often be referred if needed. You can certainly double check with certain advocacy organizations like Lymphoma Canada, for example, would be a great resource to look into. There's also a website called clinicaltrials.gov, and that is an international resource that has clinical trials listed all around the world. So you can actually search your specific type of lymphoma. You can also search for the location, and that will pull up a list of clinical trials that you might be eligible for in the future if you do need them.
Okay, wonderful. The next question is, has there been an increase of diffuse large B-cell diagnoses with people taking the COVID-19 vaccines?
So we haven't seen an increase in lymphomas or any other cancer since the COVID-19 vaccines became available. What sometimes does happen is that the COVID-19 or any other vaccine can stimulate the immune system. So sometimes the lymph nodes can temporarily increase in size. Usually that's just a benign reactive lymph node that resolves on its own after a couple of weeks. And it's fairly common. It's actually a good marker of a healthy immune response to the vaccine. But some people who previously had lymphoma but weren't aware of it, they weren't yet diagnosed, sometimes when these lymph nodes flare up after the vaccine, that can draw their attention to these lymph nodes that were already there and slowly growing, and eventually lead to them being diagnosed with lymphoma. So it's not so much that the lymphoma was caused by the vaccine, it's that the immune response and that temporary swelling of the lymph nodes may have drawn that person's attention to this lymphoma that was already developing and led to them being diagnosed.
Okay, wonderful. I think the next one is asking a bit about our health technology assessment process. It asks, if glofitamab bispecific antibody got approval in Canada, why is it not readily available?
So that's a common source of frustration for patients and doctors and nurses alike. So Canada was actually the first country in the world to approve glofitamab for DLBCL. That was back in March or April, I believe. So it's been about 6 months. But that's just the first step. So the drug first has to be approved by Health Canada, meaning that the drug is safe and effective. But then it has to be evaluated by CADTH. So that's the organization that reviews all the evidence and decides on whether or not the drug is actually going to be funded and available in Canada. So right now, glofitamab is being reviewed by CADTH. So hopefully in the next few months, we'll have a positive result to look forward to. After that, there's still a long negotiation that takes place between the provinces and the cancer boards who pay for the drug and the manufacturer of the drug. So that can still take up to another year. So it certainly is frustrating because we know it's a very promising treatment and we want to be able to use it right now. But there are some long delays until we have it routinely available. In the meantime, it may be accessible through clinical trials in some places. Sometimes there are also compassionate access programs or patient support programs where the drug company can still provide the drug to a patient, especially if there's insurance that can help pay for some of the costs. So if you speak to your doctor and pharmacist, there may be some ways that we can help access it in the meantime.
Okay, wonderful. The next is, would you comment on the effectiveness of chemo plus stem cell therapy as first-line treatment instead of just chemo, is there an advantage to getting stem cells right away?
That's a great question. About 10, 15 years ago, there were a number of trials that came out looking at this question. So one of the trials that was done here in North America, it compared 6 cycles of CHOP to 6 cycles of CHOP plus a stem cell transplant. And it did find that the stem cell transplant tended to increase the cure rate by about 15% overall. The study has changed practice in some areas. There are some centers where we do first-line stem cell transplants, especially for patients who have very high-risk lymphoma, but it hasn't been as widely taken up at other centers as well. For one reason, despite increasing the cure rate, the study didn't show an increase in survival. So patients can still receive stem cell transplant if the disease relapses, and many centers prefer that approach instead.
Okay, wonderful, thank you. The next question I have is, could you talk about the prognosis and treatment options for primary mediastinal B-cell lymphoma?
Yeah, so this is another subtype of diffuse large B-cell lymphoma, and it tends to occur in the chest, just above the heart. That's where the word mediastinal comes in, and it often tends to present with a very large lymph node in the chest. And it tends to affect younger patients, so it commonly occurs in women, especially in their 30s or 40s, but it can occur in any age group. The good news is this is actually one of the most treatable and highly curable types of diffuse large B-cell lymphoma. So with 6 cycles of R-CHOP, we found the cure rates are extremely high. There's always been a question as to whether or not we need to use radiation, but a recent clinical trial just came out actually, which showed that patients who are in a remission after R-CHOP do not require radiation treatment. Their prognosis is so good and they can be spared from radiation, which does have some long-term side effects, especially to the chest. Some centers do use other more aggressive chemotherapy instead of R-CHOP, like EPOCH-R, in the hopes of reducing the risk of radiation, but that varies a lot from center to center.
Okay. The next question related to stem cell transplant as well. The doctor in the breakout session did not mention an allogenic stem cell transplant for diffuse large B-cell treatment. Is this an option?
So I focus most of the talk on an autologous stem cell transplant or an auto transplant, and that's a treatment where we use our own stem cells. That's a much more common stem cell transplant. It also has a lot fewer side effects compared to an allo transplant. An allo transplant involves using a new donor immune system. So it's a much more complicated procedure. It has higher risks because the new immune system can actually reject the body and cause what we call graft versus host disease. So because it does have so many more risks, we tend not to use it as much as we use an auto transplant. And now that we have newer options like CAR T-cell therapy and soon bispecific antibodies, we tend to use them because they're a lot more effective and a lot safer. And nowadays, it's very rare to have to use an allogeneic stem cell transplant for this lymphoma.
Okay, great. Let me see. What factors, if any, put me at a greater risk for relapse for my diffuse large B-cell lymphoma?
So it depends a lot on a number of factors. I mentioned in the talk, there's something called the IPI score, which includes 5 different factors, includes age, certain blood tests, the stage of the cancer, as well as the general fitness of the patient. And that can help us kind of predict what the cure rate is going to be looking like with R-CHOP. There are certain genetic factors as well. We mentioned double hit lymphoma with these specific gene changes. Probably the most important thing, though, is how well the R-CHOP chemotherapy works. So patients who have a very good response to R-CHOP, they're in a full remission at the end of treatment, tend to have a very good prognosis, and the risk of relapse is much lower in that situation.
Okay, wonderful. And I think this will be the last question for this session. It says, are there factors that put me at higher risk of experiencing side effects like CRS, cytokine release syndrome, or tumor lysis syndrome?
Yeah, so cytokine release syndrome is a side effect that we can see with CAR T-cell therapy, where the CAR T-cells start to attack the cancer and release a lot of inflammation into the body. So that can vary depending on a number of factors. Probably the most important is what we call tumor burden. So it's how much lymphoma there is present in the body. If the lymph nodes are very large or very widespread, there can be a higher risk of cytokine release syndrome. The good news is with very close monitoring, treatment in hospital, and early use of steroids and other anti-inflammatory medications, we can usually help treat the cytokine release syndrome before it gets out of control.
And doctors are really looking for this because they recognize it's a potential side effect, correct?
Exactly. So that's why most of the time patients are actually in the hospital for the first 1 to 2 weeks after CAR T-cell treatment. And we
Okay.
monitor very frequently and we treat cytokine release syndrome. So in most cases, it's quite manageable.
And how about the tumor lysis?
So that's not so common with the CAR T-cell therapy treatment. It can occur with chemotherapy, especially in patients who have, again, very aggressive disease or if it's a very high burden of disease. But we also monitor for that, and we also have medications that can help to prevent tumor lysis and help the kidneys and other organs.
Okay, wonderful. I think there might be some other additional questions. If they haven't been addressed today, it looks like we have quite a few of them. We will definitely send out some information related to answers for those questions when we send out the video replay links. In the meantime, I would like to thank Dr. Puckrin for taking the time to participate in today's conference sessions. Very much appreciated. We hope those watching today learned something new about their or their loved one's lymphoma subtype, and that we answered most of your questions. From here, please tune into the closing remarks in the auditorium, which will be starting in a few minutes. Thanks very much.
Thanks so much, everybody. Have a great day.
Take care.
Bye.
Bye.